there's a lot of information that was covered today, and some of it was also contained in my presentation as well. But what I want to focus on, which I think is very important for the Commission to hear, is that we heard a lot today about national statistics, about the impact of trauma on children, about some national models for intervention. And it's important to know that we actually have a lot of resources and assets here in Connecticut that have been in place for some time. And I want to tell you a little about what those resources and assets are. I'm going to skip through that because we already talked about it. In Connecticut, we actually do have some information about the exposure of trauma to children in various systems. So we actually are aware that in our outpatient child guidance clinics, according to all the data that is collected systematically across the state, 53% of children on intake report that they have been exposed to trauma. We actually know more specifically in 22 agencies that we've trained in trauma-specific interventions that ranges between 60 to 80%. And to support Dr. Ford's presentation earlier, we actually know that the average numbers of traumas that children experience are 8. So for children seeking outpatient treatment in our clinics across the state, on average, those children have experienced 8 different forms of trauma. So important to remember. We also know that in our juvenile justice system, as Dr. Ford mentioned earlier, about 80% in our detention system report a history of trauma, and about 50% or so are symptomatic with either partial or full PTSD. We also know, and I actually don't have this on the slide, that through our emergency mobile psychiatric service system, which sees about 11,000 children per year, about 53% of those children also report that they have experienced trauma. So just in those systems alone, and also it's over 20,000 children in Connecticut. If we add in the EMPS numbers, that grows to about 25,000 at least. So we're talking about a tremendous number of children in our state that have been exposed to trauma. As Dr. Mehrens and others have established, it doesn't mean that all those children are going to be symptomatic. But we do know that in clinical samples, clinical populations, the likelihood of experiencing some symptoms as a result of exposure is higher than usual. And conservatively, we could say that at least 25% of those kids are probably experiencing some type of trauma. We already talked about the fact that these traumas could be wide-ranging. There's a variety of different forms of trauma that children experience and do experience. When you look into the types of trauma that children experience, when we look at the data that we've collected in those 8 different forms of trauma, it's a range of different experiences. It's community violence. It's experiencing domestic violence. It's being the victim of violence themselves. So this layering effect that Dr. Ford described. I'm not going to go through the reactions to trauma because I think that was well covered. I do want to point out that there is a risk for misdiagnosis, and I'm going to talk a little bit more about training pediatricians. And oftentimes when I train pediatricians in recognizing the signs and symptoms of trauma, one of the sort of bells that goes off for them is that they may have been missing kids in their practice or seeing them as suffering from other disorders, when in fact it may have actually been related to a trauma history or child traumatic stress symptoms. So there's a range of different disorders, and when you begin to look at the way these disorders are diagnosed, many of the symptoms overlap with child traumatic stress. So if you see a child that's having difficulty regulating their behavior, if they're having difficulty maintaining their behavior, their composure in a classroom, it'd be very easily to identify that child as perhaps having an attentional deficit disorder or a conduct disorder. Yet that child may be suffering, in fact, from a child traumatic stress-related condition. This was actually also mentioned earlier today, and I guess it's good that many of my former mentors actually have trained me well. But the adverse childhood experience study that was conducted really showed the relationship between these early childhood negative experiences and lifelong health and mental health problems. So I want to emphasize, and this was said earlier, that if left untreated, many of these conditions and disorders could lead to lifelong problems that can cause both disease and disability. It also was established, and I just want to also remind folks, that there's a linkage between being a victim and later going on to offend. And you could look at some of these statistics in more detail, but in many cases, your risks for being involved in the juvenile justice system or being an offender more than double if you've been exposed to trauma, if you've been a victim, or if you've also encountered maltreatment. So it's a very well-established relationship between being a victim or being maltreated and then later going on to offend. One study actually showed even more dire consequences. Linda Teplin, who does a lot of research with juvenile justice populations, recently released some data that she's analyzed that shows that in the longitudinal sample she's been following, about 10% of the kids that she's identified as having traumatic stress issues have died within about a 10-year period. Incredibly dramatic results. And these are kids that she saw first in childhood and in teenage years. 10 years later, they're dead. It's been argued by Vincent Felitti and others that trauma can really be seen as this public health issue, and it could also be seen as a preventable issue if we identify and intervene early. And we could actually prevent some of the most significant social ills as a result. A cost analysis study that was done in 2007 estimated that the annual cost to the United States for child maltreatment resulted in direct and indirect costs totaling $104 billion. So when we're talking about budget saving and how we could actually save money in our federal budgets, this is a place we should be looking. The former president of the American Psychiatric Association made the metaphor that really, trauma is to mental health as smoking is to cancer. We really have to think of it in that public health way, in much the way that Dr. Painu's mentioned earlier today. It's very important to know, though, that there is help available. You asked about evidence-based practices, models that work. We actually have introduced and disseminated evidence-based models across Connecticut, and not only have we disseminated them, but we've evaluated their effectiveness. We haven't just relied on the research that says, hey, these models work. We've looked at their efficacy, and we've seen some excellent results in our samples in Connecticut. We actually, probably about 10 years ago in Connecticut, began looking at the issue of mental health. I direct a Center for Effective Practice at the Child Health and Development Institute, and that center was originally created looking at this issue of how do we improve the standard of mental health care in our state. How do we work with state agencies, our partners at Yale and UConn, other major institutions, to advance our knowledge about our best practices? How do we increase and improve the level of care being delivered by our providers? And how do we work with our state agencies to ensure a quality of care? And we've actually made a lot of progress in the past decade in that area. Three things I want to highlight today, and this is very important for the Commission to know, is that we've actually been involved in really trying to create a statewide trauma-informed system of care through a variety of activities. And this actually precedes any of the horrific events, of course, that we have experienced in Newtown. We actually have been working to implement systematic screening and identification of children who've experienced trauma. And we actually have done that through a variety of ways. We have trained, as I said, to date, and we're planning on training more, 22 outpatient child guidance clinics across the state. All of those child guidance clinics universally screen all of their children coming in for intake for trauma. We also screen trauma, thanks to Dr. Ford and others, children in detention for trauma and other mental health issues. So we actually have very good data on children in our juvenile justice system who experience trauma. We are right now in the middle of a federal grant and are working with the Department of Children and Families to implement universal trauma screening in DCF, in the child welfare system, and I'll tell you more about that in a second. I have been working across the state through our EPIC program, which I'll discuss in a little more detail, to implement a training for pediatricians, school nurses, school social workers, and other healthcare providers in screening for trauma, and then also the training of law enforcement in identifying trauma, spearheaded by the work in New Haven through Dr. Marins. We've also implemented a range of evidence-based practices in the state. The one that we have implemented most widely is the trauma-focused cognitive behavioral therapy, which I will talk about a little bit more in a second. But this particular model, we're actually In the United States, we're one of the few states that has a statewide dissemination of that model. So it's important for you to know that. We live in a state that actually has made significant efforts to training its provider community in an evidence-based trauma-focused practice, as well as Dr. Ford's target model, dialectical behavior therapy. We are going to be training agencies in Dr. Marin's CFTSI through the federal grant, as well as a therapeutic drama model. We also have trauma-informed approaches in our congregate care settings. We've actually trained, which is formerly Riverview, Solent North and South in TF-CBT, as well as our training school staff in TF-CBT. We've also implemented the risk and connection and restorative approach in those agencies. So there's been a lot of effort to try and build our system of care across the state. 2 years ago, we were one of the 5 states in the nation awarded an Administration for Children and Families, which is the division of the Federal Health and Human Services Department, a $3.2 million grant to implement a trauma-informed child welfare system. And so we've been working with Dr. Marins and other experts from around the country in TF-CBT, as well as our local folks here at DCF, to focus on 3 main areas: workforce development, training our child welfare staff on how to be more trauma sensitive, understand the impact of trauma on children. We have been implementing, and it will go live in 2014, a universal trauma screening, and we've been working with folks from the Child Study Center and others to develop that screening protocol. And we've also been disseminating, as I said, trauma-focused cognitive behavioral therapy to additional agencies, linking those agencies to their child welfare counterparts, as well as we're going to be doing the same over the next 2 years with CFTSI, which is the Yale model that Dr. Marins described earlier. The EPIC program, which I referenced earlier, is a program that was developed at the Child Health and Development Institute and with the local chapter of the American Academy of Pediatrics. And it's a model that uses academic detailing. So you know the sort of classic pharmaceutical salesman who comes into a pediatric practice and works with the staff to deliver information about their product. We use a similar methodology to meet with staff. Usually it's over lunchtime of a pediatric practice. We provide them with training on a variety of topics, everything from developmental assessment to screening for autism, and now most recently we designed and implemented a trauma model. In that trauma model, we educate pediatrics providers about the impact of trauma on children, recognizing signs of symptoms of trauma and child traumatic stress, and then we also introduce using a standardized tool that they could actually use to screen children in their practice. We then also bring with us a local community-based provider who provides trauma-focused services. And that's a very important part of the work, because that provider is their link to making, once they identify the children, to making referrals in their community. So we've just begun delivering this module, and ironically, the module went live about a month before the Newtown shootings. And it was, we actually had trained the Danbury Hospital staff several weeks before this event took place. And luckily, Dr. Marins and his team were actually able to provide some follow-up and provide with some individual consultation. We have trained 21 pediatric practices to date in that model. That includes 392 physicians, nurses, and staff. And what's most notable is in our partnership with the State Department of Education, following Newtown, there was a tremendous outcry, and you can let your son, the principal, know this, that for training in recognizing kids who are experiencing trauma and how to link them to community-based services. So since the Newtown incident, we have had a tremendous outcry from school districts across the state. We've trained 10 school districts, which includes 728 school nurses, psychologists, and social workers using the EPIC module to train in screening and identifying children that are at risk. That entire endeavor was funded by CHDI's parent foundation, the Children's Fund, which wasn't anticipating, obviously, the need or interest in this particular module. the State Department of Education has expressed interest in wanting to eventually train all schools across the state in using this module. And clearly, 21 pediatric practices is just scratching the surface. But we have to date, this is just in the past 4 or 5 months, trained over 1,000 professionals in this module. Also, as I mentioned through the concept grant, we will be introducing universal screening of child welfare staff so that when child welfare staff are working with children and families, they will be identifying whether or not there is a trauma history and linking those children and families to community-based providers. It's anticipated that once that is up and running, we should be screening about 14,000 children per year. As I mentioned earlier, we will be disseminating the CFTSI module, which Dr. Marin's already briefed you on, and we are continuing to disseminate trauma-focused cognitive behavioral therapy, which DCF had actually funded the original dissemination of in 2007. This particular model has over 8 randomized controlled studies that show its effectiveness. We also know through the National Child Traumatic Stress Network that is shown to be effective in multiple real-world settings all across the country. We actually coming from the National Child Traumatic Stress Network before I came back to Connecticut, I really felt this was an important intervention we need to introduce. And the Department of Children and Families, we worked really collaboratively with them to disseminate this module over a 3-year period to 16 agencies. We train agencies using a learning collaborative approach. So we just don't do a one-shot training. We actually bring multiple groups of agencies together to learn over the course of a year. We have 4 or 5 in-person learning sessions. They practice the skills in between. We collect data all the way through, and we ensure that the practice is embedded at the agency with fidelity. And we've shown some very good outcomes as a result of using that methodology. We actually have, to date, as I said, trained 22 agencies. Right now, any family in Connecticut should be within about an hour's drive of receiving treatment. There are many centers in our urban areas, Clifford Beers being one of them, treatment at the Child Study Center in New Haven, here at the Village in Hartford, and many other centers across the state. One of the challenges is despite having so many agencies trained, there's limited access. We really are only beginning to scratch the surface of some of the need. And we also hear from providers that it's challenging for them to deliver this evidence-based practice because the typical Medicaid reimbursement or private insurance reimbursement they might receive doesn't really cover their costs of delivering the service. So this is a real challenge that we face as a state. We have an evidence-based model that works. We have a trained workforce, but they're finding it challenging to deliver that in some cases for financial barriers. We also are seeing that there are a low number, we're not anywhere near the capacity we would like to reach in terms of the capacity of the agencies we have trained. So we're trying to put more efforts into quality assurance and ongoing training due to issues such as staff turnover to make sure that we have trained clinicians. Just to give you a little snapshot, as of September 2012, we've seen over 2,000 children with TF-CBT in Connecticut. These are some statistics about their background. The one thing I just want to note is that the most common traumatic events they cite are sexual abuse, physical abuse, injury, death of a loved one, and separation from a caregiver. So these are the kinds of issues that children who are experiencing trauma are experiencing. And as I mentioned before, they're averaging about 8 different trauma types per child. This is just a snapshot of a sample evaluation that we conducted of some of our outcomes, and we're actually seeing significant decreases in children who complete treatment in both their depression symptoms and their PTSD symptoms. We're very proud that actually these results in our community-based settings are comparable to the treatment developers in terms of their effect. And we're actually seeing, if you go back and you look through the criteria in which these children were diagnosed for PTSD, in about 82% of the children served, they would actually have a remission of that diagnosis. They would no longer qualify for the diagnosis following treatment. We've also seen some other benefits of disseminating this model, including reduced no-show rates of families receiving treatment in the clinics. increased staff morale. We're hearing from clinicians, wow, I really feel like I'm being effective, that I have a model that works. I've been seeing some of these families for years, and I haven't been able to be effective with them. Now I'm actually making a difference in their lives. We're seeing shorter lengths of stay in treatment. On average, the TF-CBT treatment takes about 5 to 6 months, and we're seeing symptom reduction in that time. And it's likely that we're going to be seeing significant future cost savings, because these are families that are actually being discharged and they're being restored to functioning. Not to say that some of these kids don't come back into treatment in the future, but we're seeing it as a very highly effective treatment to get them back on track. Here is a map of where our providers are across the state, and you can see that we've done a fairly decent job disseminating the model. There are the usual pockets. We have one more dissemination. We're going to be training approximately 6 more providers in TF-CBT next year. Hope to target the areas that are underserved. And we will also be disseminating CFTSI in the following 2 years. So just in summary, I think it's, as was well established today, in Connecticut, childhood exposure to trauma is a significant public health issue. We can't ignore it. It's important that we identify these kids and identify them early. If we don't identify them early, if we don't screen and link them to appropriate services, they are likely to have they could have potential lifelong difficulties, and they could also result in tremendous cost burden for the families as well as for our state if we don't identify and treat these issues early. It's important for all of you to know that we have a range of services in place. These services may not be fully implemented. We may not be reaching all the affected children and families, but we're not starting from scratch here. We actually have had some very significant efforts made in the state, and by bolstering and supporting the work that has already been ongoing, we could definitely move in the right direction. It is important to know that there are issues of capacity and access to services that work, and that I really want to bring the message today that we have to examine as a state when we're delivering effective models of care that in some cases require additional time, supervision, attention to the delivery of services. We also have to recognize there may be a cost burden for the providers who are providing those services and ensure that they're reimbursed adequately. Some of the challenges that we face, we definitely need to continue our training of professionals that have contact with children, especially in pediatrics. In many cases, when we do train providers in communities, there are a lack of trained clinicians and providers for those clinicians to refer to. What I hear time and time again when I work with schools or pediatricians is, if I see this problem, I want to know what I can do with it. I need to know someone to turn to. I need to have someone to call on the other end of the line. It's not enough for me just to know this is a problem. I need to be able to know what to do next. I actually spoke with a friend of mine from college recently who called me because her son was involved in the Boston Marathon bombing, and he was very close to the blast. And she said to me, I called my pediatrician, and he didn't call me back. She said, so I called again, and when I spoke to him, he said, I'm not really sure what to do. And this is an example. Families often turn to their pediatricians in times of crisis. We have to ensure that our pediatricians are equipped to deal with these types of crises. As I mentioned, there's a limited capacity of our existing providers. We do hear complaints that those with private insurance have difficulty accessing these services. I often am challenged by friends and colleagues who ask me for a referral to identify clinicians who are trained, who could actually provide these types of services. We also, in our state, have very limited services for young children, ages 0 to 5. We do have the dissemination of Child First, but that's for only the most needy, high-risk families. We need to look at other models of care and practice to intervene with children in their younger years. We have very limited trauma-focused treatments in our schools and limited access in our schools. So one step is training schools to identify these issues. The next step is building the capacity of schools to respond through our school-based health clinics, through linkages with community-based services. As I mentioned, it takes extra cost and time to utilize some of these services, and we do have to address the issue of staff turnover. We also just can't train folks without paying attention to the service. One thing that I've learned in doing the work that I have at the state level, it's an ongoing process of ensuring quality of care. Our children and families in our state deserve quality of care, irrespective of where they go for treatment in this state. They should have access to a similar level of quality of care, and it requires ongoing quality assurance and training to make that happen. So my recommendations are that we need to build and strengthen a trauma-informed system of care across our systems, including pediatrics, behavioral health, early childhood, schools, child welfare, and juvenile justice. We have to make sure that we have training in place for all of those sectors. We have to ensure that there are adequate providers to provide trauma-focused treatments. We have to build the capacity of existing programs to meet the need of children and families in our state. We have to ensure that, irrespective of insurance status, that children and families have access to these services. As I mentioned, we need ongoing training and quality assurance for these programs. We have to ensure that there are increased access to trauma-focused service in juvenile justice settings, given the number of children that are exposed to trauma in those settings. We need to increase the range of evidence-based services available, particularly for those early childhood, young children, and also for children in school-based settings. We have to ensure that providers have appropriate incentives, whether it's reimbursement or other incentives, to deliver quality care. And then we also need to collect outcome data to ensure that these programs are working.
Thank you very much, Dr.